To begin our afternoon, Eric Shell will identify a set of important strategies for rural hospitals to ensure they are successful as the industry transitions to create true patient value. Eric has more than 28 years experience in healthcare financial management and consulting. Since joining Stroudwater Associates in 1997, he has helped rural hospitals improve financial and operational performance by employing effective strategic, financial, and operational plans. Eric currently serves on the National Rural Health Association's Governmental Affairs Committee and Rural Health Congress, and has served on the Federal Office of Rural Health Policy's Rural Hospital Issues Group. Please give Eric a warm welcome.
Thank you. You can hear me okay back there, way back there? I pity you guys when you see my slides here in a little bit. I hope you printed it all out. Boy, I can't even see you. I was listening to the presentations earlier this morning, and I can't I can't stop thinking that we spend a lot of time looking at data, and data is a lot of data that we see out there is a reflection of performance of rural hospitals in a fee-for-service payment world. And we have a world that's going to be completely 180 degrees from fee-for-service. Financial statements, financial performance is essentially gap basis accounting of revenue recognition in a fee-for-service world that essentially is going to no longer exist. And and I'm glad Mike from My Vantage was able to start talking about kind of measures in this new world, because in the future it's going to be about our future economic value that is going to be where we're going to have kind of how we're going to fit within the system, and not looking at historical fee-for-service gap basis accounting statement. And I just want to say that as we open up, because this presentation is really about what this new world is going to look like and what do we got to do to get there. It goes back to this Eric Hoffer quote, this famous quote from Eric Hoffer. Many of you know that this in times of rapid change, the learners we're going to inherit the world, the earth, while the learned are going to find themselves perfectly fit for a world that no longer exists. And we've got to figure out what this new world is and make sure that we're the learners and fit within that world. So let me get going with this talk. I feel like I'm interrupting lunch right now, and dessert. Clearly, I don't know where the dessert is, but hopefully these mints aren't dessert, because I'm eating in front of you at this point. But this is a three-part talk. The first part is about where the market's going and why it's going. And I think the why is the really important thing. A lot of people see it, but they don't understand why. And hopefully, maybe in this room you guys have all figured it all out, and this I'm just a little bit below and slow here. But let's figure out where it's going and why. The next thing is what's the rural value, the very unique value rural hospitals bring to this new equation. This is the good side of my talk. So all of that kind of sadness that we had earlier today is going to go away, and we're going to talk about how we have incredible value in this new world as rural hospitals. The third piece of the presentation is going to be about if this is where and why the market's going. If we have unique value, how do we get there? Recognizing that we as rural hospitals don't have the reserves to make a mistake here. And so how are we going to get there? What are those very specific strategies? And I've got some ideas for that. Before I start, I always start with qualifications. I'm an Arthur Anderson trained CPA, so creative and smart. My slides. There's too many of them. There's 60 slides in there. There's too many of them. Some of them I've made changes as of 10 o'clock this morning, so there's some changes that you're going to see. The fonts are too small, but at the same time, they're interesting, because at some point you may actually want to look back on these slides and say, hey, he said something there. And so I consider them kind of a reference guide if you guys care to look at it in the future. And I'm glad that many of you have printed them out, because I don't even know how you guys in the back. I came in there earlier today. I don't know how you guys are going to see this. The second qualification I'm going to have is I have never gotten through this presentation on time. Not once. And I have given it in South Carolina in 60 minutes, and 2 weeks ago in Juneau, Alaska in 6 hours and have never gotten through this talk. So let's just go with it. If we get to a point, we'll finish. We'll finish one way or the other, obviously, but we may not get through all of the talk. So let's just take out of it what we can get. So those are my qualifications. Let's get going into this thing. I always start this talk with kind of the history of the origin of this talk, because it's really interesting. 4 years ago, Louisiana Hospital Association, they called me and they said, Eric, our rural hospitals are sensing something's different in the marketplace. And what we want you to do is we want you to come down to Louisiana, and we're going to pull together 14 CEOs of kind of leading rural hospitals within the state. And we're going to form a task force. And over the next 4 months, we're going to meet one day a month for 4 months. And what we want to do is identify what are the root causes of some of these things that are going on in the marketplace. And if we can figure out the root causes, then we can start to get proactive in developing strategies to get in front of some of these things that we see as challenges going on in the market. Out of that came the kind of the chassis of this presentation. 2 years later, the Tennessee Hospital Association took it and said, hey, that Louisiana project was interesting, but we're going to take what they did and come up with the next round of that. And so a lot of what you're going to see today was the work of Louisiana Hospital Association, rural hospitals, peers just like you, Tennessee Hospital Association, peers just like you, rural hospitals, that came up with this. Now, what I like to do is essentially in 90 minutes, take you through their experiences. And their experience was, essentially redo this project for everyone in this room. Starting off with talking about what's going on in the marketplace. What's going on with legislation? And the key piece of legislation that we're really now feeling is Obamacare and the Affordable Care Act. Talk a little bit about that. And then kind of go through this exercise to say, okay, let's define this root cause and figure it out. And we'll see if you guys come up with kind of similar responses as Louisiana Hospital Association and Tennessee. I will tell you, in the last 12 months, this presentation has gotten 10 times more relevant than it was for Tennessee and for Louisiana. What they predicted is coming through in ways that they would not have imagined back 4 years ago. So again, it's always important to start with that history of this talk. And so let's start where they did. They said, here are the things that we're seeing in the marketplace that are different. We're seeing kind of crazy affiliations going on. We're seeing urban hospital, rural hospital, urban hospital, urban hospital, insurance companies acquiring doctors, insurance companies acquiring hospitals, hospitals acquiring insurance companies. All this goofy stuff's going on. What's going on there? We're seeing volumes flatten for the first time in 30 years. In a fee-for-service world, patient volumes were going down. What's that about? And we're seeing kind of physicians increasingly coming into the employed model of the hospitals. CEO turnover, really interesting. CEO turnovers at really high levels. I gave this talk. It was the opening keynote at the Georgia Trustees Conference back in January. At their whole the whole Grady Health Systems was sitting there, all these big guys, and they said in the previous 12 weeks, there were 17 CEO turnovers in the state of Georgia. Remember I was saying this presentation is more relevant today than it was, so all of these things were the symptoms that the Louisiana Hospital Association said, we want to pull together a group and figure out what is going on here. They said, hey, was it Affordable Care Act? Was it Obamacare? Is that it? And as soon as we throw that bum out of the office, it's going to go back to normal. I don't know, maybe Medicaid programs, maybe commercial insurers, all of these, but ultimately there's some uncertainty. And the uncertainty that they had predicted, or actually that was in place in 4 years ago, is a whole lot more uncertain today than it was then. So let's kind of take a look at some of the things going on in the marketplace. And obviously this presentation was updated. I was updating at 10:15 this morning. And of course Tori is like, oh, seriously? You're one of those guys? Because I want to give you the current experience of what they went through. So all of these things are going on. High deductible health plans and the effect that they're having. This was a quote from a CEO of a manufacturing company that we had worked with years ago. We just renewed our high deductible health plan going into what, the third year? Guess what? A 5% reduction in premium. What does a 5% reduction in premium to a health plan mean to all of us in this room? 5% less. Whether it be payment or utilization, it's less. Needless to say, everyone is thrilled. Not sure what the average health savings account balance is, but I think it is high. Doing what it's supposed to do, turning patients into consumers. This is new. This is different. Has anyone seen a patient with a high deductible health plan? They're not allowed in the state of Iowa. I have a $4,000 deductible. My company funds that, all $4,000 out into an HSA. Very different consumer choices now. I used to go, I went through a series of getting MRIs and meniscus surgeries. It used to be I go to the surgery center, I went to the surgery center, or the imaging center, because the parking was right outside the door, and I could go at 9 o'clock after I got done swimming. I could go to the imaging center at 9 p.m., take a nap while they're doing my knee, and be all set. Now, there's a new element of that, and it's price. And frankly, the surgery center is a lot cheaper than the Maine Med or Mercy Hospital, the hospitals in Maine. And so, consumers, this whole thing is a big change. Underinsurance, the state budget deficits, and how states are dealing with, some states are taking very proactive approaches and moving towards accountable care. These states like Oregon, where they've developed 16 community care organizations, where there are alliances between insurance companies, provider organizations in different regions of the state, all to take essentially a capitated payment. Alabama is rolling out now with something called RCOs, regional care organizations. When's the first time Alabama was proactive in anything other than college football? Is there anyone from Alabama here? Sorry. Sorry. It's not very nice of me. But very proactive. They're rolling out, essentially what they said is, by the time 2018, I believe, they want to cut 11 checks to provider-led organizations to cover all their Medicaid beneficiaries. Really interesting. And then you got some states going back to managed care, and we'll talk about why that's not there. You got all these other things going on, and I got some slides on the recovery audit contractors, reduced readmissions, some of these other things. And let me just go through some slides. High deductible insurance companies. This showing that in small businesses, 63% of small businesses now have some form of a high deductible health insurance. And I point to small businesses because that's what mostly is in our rural communities. Again, turning patients into consumers. There's that new value equation now applied, where I'm not just looking for convenient parking. I want price. I want to know what the cost is going to be to me. This is looking at, even for those patients with insurance, the rate of underinsurance. The Commonwealth Fund did a study this summer that looked at small businesses with patients with insurances, and the uninsured rate, underinsured, has gone from 12% to 27% between 2003 and 2014. Significant piece of those with insurance are now considered underinsured. And that's ending up in bad places in our income statement, mostly bad debt. Or the rate of readmissions has gone down. Again, this is just, what with some of the value-based payment programs in place through the Affordable Care Act, we're seeing the rate of readmission go down. And oh, by the way, this was all revenue to us at one point, volume, that is now coming out of the system. And I tried to get an updated slide on here. It's not yet out. I know that's pretty old data right there, but I bet you this number is continuing to come down. Again, revenue at one point. How's it playing out in Iowa? Look at this. These are inpatient acute admissions. In 2008, you were at 125 discharges per thousand in Iowa across the state. Look what's happened in just, 6 years. Again, volume coming out of the system. MACRA. Has anyone really stopped and thought about the impact of MACRA and the physician? This is the physician fix, the SGR fix that was passed. Incredible implications of this whole transformation in payment from fee-for-service to value-based payment. This was, first of all, this was bipartisan. So anybody thinks that getting Obama out of the office and replacing him with Trump or whoever we replace him with is going to change the way we look at the movement of the transformation of payment from fee-for-service to population-based payment. This was a statement in Washington, D.C., that we're on board with this new world of payment. The second thing this MACRA has done, it gave us a time frame for how soon the transitioning payment system is going to occur. We used to just point out there and say, oh, it's going to occur sometime in the future. CMS says we're going to have all our, 50% of payment in population-based or alternative payment models by 2018. But yeah, that's CMS. They've been wrong before. MACRA changes it. It's given us a time frame because essentially what's happened through MACRA is there's two components. By the time, first of all, from 2016 to 2019, physicians are going to get a 0.5% increase in payment. That's not a whole lot to cover some of the costs that they're incurring. The ICD-10 conversion, the costs of the electronic health record and what that's done to the efficiency within our physician practices, all of this stuff. Then between 2020 and 2025, there will be no increase, and physicians will go into two tracks. These are employed and private. These are all physicians. They're going to go into two tracks. First track is, hey, if a certain percent of your payer mix are in these alternative payment models, you're going to give you a 5% bonus payment. And then you're going to have the incentives inherent in whatever you negotiate as part of, if it's an ACO or whatever that is. If your physicians or your employed physicians or community physicians are not in that group, they're going to be in the second category called a merit incentive payment system, where they're going to be compared relative to their peers around four areas: resource utilization, adoption of electronic health record, quality, and clinical practice improvement. And they're going to be compared, and depending on how they score relative to their peers, over time they could have payment differentials anywhere from like minus 20 to plus 15 or 20. It's incredible. I was at a conference last fall in Nebraska, and a physician was speaking. A physician that was in a big ACO, primary care group. He was speaking about this, and he said, you CEOs of rural hospitals out there, let me tell you this. Your physicians are not going to want to be part of this. And so they're going to be looking, whether they're independent or employed, to be bucketed into these new alternative payment systems. And if you as hospitals don't kind of understand that, it's likely many of your physicians are going to go by you. Very interesting, this, like I said, this guy, Serpa was the name of his physician group. Large, multi-site primary care practice, operating as an ACO, already with his physicians, and just saying, hey, here's something they're all paying attention to. And then going forward. So I just had this slide in here. This is one of those, here's what this merit incentive payment system looks like. Some more details on that. Adjustments to fee-for-service. You could have negative adjustments of 4% in 2019, 5%, 7%, 9% in 2022, with positive adjustments on the other side, if you're in that second category of MIPS. And again, the time frame, if you go back and look at this time frame, here's the time frame where we've got to start saying alternative payment systems are going to be big time, somewhere in this area. And this is going to play out. Kind of remember this when we get to the second section around strategies, because this is all going to come playing in. Some implications, hospitals and health networks came up with this back when MACRA originally came out. They said, hey, there's some really important implications that we got to be thinking about here. And I like this one a lot. Hospital participation in patient-centered medical homes, bundled payment, and accountable care organizations as partners with their physicians is going to be a business imperative, and especially those that are independent in their communities. Hospitals not active in these pursuits, non-employed physicians might find business partners with capital, expertise, and infrastructure elsewhere. I've got some slides to show you where that expertise and capital may be coming from to your communities. And then the 0.5% payment increase is just not going to be enough, and physicians may be looking to come on and kind of come under the fold of the hospital, which frankly I think is is partnership is a good thing. Now, what's really fascinating about this MACRA, a couple weeks ago I was presenting in Alaska to there was probably 20 physicians in the room, and not one of the physicians had even heard of this. And I think what's going to happen as we start to get the word out there, you all should be probably having some discussions with your medical staffs in your communities talking about this, or maybe Iowa, you're really well informed, but a lot of this is just, they're not aware of these changes that are coming to them. we spent a lot of time early this morning, great presentation from BKD folks around this comprehensive CJ, I like that, CJM or whatever they called it. But really interesting analysis and great understanding of the impact that this is going to have to critical access hospitals. And I think they're right on. I think they're right on. So kind of this slide is kind of the last section around kind of what's, all these things that are going on in the marketplace. And if we step back and we look at what's going on in the marketplace and what we're seeing, we live in a world right now of price times volume is net revenue. Right? You do the math. Price times volume is net revenue. A lot of what's going on here in the marketplace between increased consumerism, the readmissions, the RACs, all of this are attacks on half of the equation there, which is utilization. The market is coming after that utilization side of this pillar of price times volume is net revenue. And so, gosh, when half of this pillar is attacked, what do we got to do to maintain net revenue? Well, we got to figure out a way to increase price. Anyone tried negotiating with Blue Cross lately? So then let's just spend a few minutes. Gosh, I was just thinking Obamacare was passed 6 years ago yesterday. Wow, did that go fast. And now we're really starting to see some of the impacts. But I look at the impact in 3 areas related to rural hospitals. First, more people with insurance. And for all of these reasons, more people with insurance. Some of the issues that I have with that as it relates to critical access hospitals is traditionally underserved areas and populations are going to have increased provider competition. This probably isn't such a big issue for you all here in Iowa because your underinsured has been relatively low compared to some of the states that I know Mike Topchik talks about, Mississippi and some of these other states that I've had a chance to see. And then this issue, but this is going to be, rural has always been kind of defined as an area that has a higher percent of under and uninsured relative to urban. And if everyone now in rural over time is going to have insurance, isn't rural a much more interesting place for others? And I would suggest, yes, increased competition. And how's that play out in Iowa? So the Gallup poll did a study this summer. And look at some of these states where you see the uninsured rate. Last year I worked with a critical access hospital in Kentucky, and their uninsured or their bad debt was 19.5% of gross charges before they expanded Medicaid. And last year it was 7.5%. You think about that change right there. Incredible. These guys went to an operating margin their operating margin went up to like 16% because they were breaking even when their bad debt was 19.5% of gross charges. But in Iowa, it has actually played out as well. Your uninsured rate has gone from 9.7%, according to this Gallup survey, that looked at the uninsured in 2013, and then did a survey of uninsured in the first quarter of 2015. That's almost a 50% reduction in the uninsured. So this first piece of Obamacare is actually really playing out in Iowa. The second piece of Obamacare that's playing out, and this is where things get interesting, is the Obamacare said, for you hospitals that are not critical access hospitals, we are going to look at your costs as an industry, and we are going to not pay you your costs. We're going to look at medical inflation. Let's say it's 3%. And then if there's been an increase in utilization, we're going to chop something off the top there. And then we're going to take off another percent because we can. And so what's happening is your price, what you're getting paid by a major payer for non-critical access hospitals, is going down relative to cost. And then, oh, by the way, all of these other things are coming out. All of this. These, the hospitals that I've been to in the last 2 years that have, broken, essentially, balanced the books on electronic health record incentive, the EHR, meaningful use incentive money, that's gone now. Some of the Medicaid dish payments and Medicare dish payments are targeted to go start to go away through 2022. All this is dollars. But I want to go back to this idea that price by a major payer is going down relative to your cost by formula. And what does that look like? Well, here's on October 30th, 2015, this is the outpatient rule, the final rule that outpatient the regs that CMS put out. And it ends up with this statement right here. For all your outpatient APC payments for non-critical access hospitals, the final rate up will be minus 0.3%. Whose costs are going up minus 0.3%? And oh, by the way, on the inpatient side, the rule, it's the exact same thing. It was around the same, I'm not sure, maybe some of you know, it was right around that minus 0.2 or minus 0.3%. So here we go. We're going back to this pillar of price times volume is net revenue. And now price by a major payer relative to cost is going down. What are we going to do if we're a big boy? A PPS hospital? Well, we got to figure out how to grow volume. Wait a minute. Didn't we just talk about volume as an industry coming down? What are we going to do now? We got to grow our catchment area. And doesn't rural now have insurance? We're becoming very interesting out there. And then there's something else we can do, and it's kind of indirect. It's in here. And this is interesting. So the third piece of Obamacare, so first piece, more people with insurance. Second piece is the payment, your price relative to cost is going down. And the third part is we're not just going to pay. The government says we're done just paying for quantity. We want to have some value. So all of these programs came out with means of paying for other than just volume. And then they introduced this concept of the ACO. Crazy little concept. The market's response in March of 2011 when the regs for the ACOs came out. You guys remember this? The ACOs are like a unicorn, and you heard all these quotes. The market's response was, get these things out of here, never going to fly, not going to happen. Worst concept you've all ever come out with. So the feds went back over that summer of 2011, came out with new, redid some of the regs, made them a little bit more flexible, reissued the regs in September of 2011. And what was the market's response the second time around? Get these things out of here, it's a unicorn, they're never going to happen. And then what happened? Well, what happened? They happened. And they happened to the point where, through 2016, we had 25% of Medicare fee-for-service beneficiaries now in a Medicare ACO. I saw when Mike Topchick asked the question, how many of you are in ACOs? Probably, a third of the room raised your hand? How did this happen when the market said these things are dead on arrival, not going to happen over our dead bodies? This is a tsunami in the terms of healthcare movement. And why did that happen? And are they going on in Iowa? Absolutely, as you all pointed out, number of ACOs. Of course, next week I'm going to be back in Alaska, and it's kind of the one state in the union. There's just nothing there. They discount their charges 2% for all their commercial insurance, and fee-for-service is 18% operating margins. And the rate of growth. Now, I want to show you a couple things here on the rate of growth. So the dark blue line are physician-led ACOs. The red line are the larger system-led ACOs. And you're seeing physicians kind of at one point ahead, but essentially running neck and neck with the system-led ACOs. Why are the physicians so interested in these ACOs? So picture this group, SERPA, in central Nebraska that might have 10, let's just say they have 10 primary care sites around. Many of them have critical access hospitals in their practice in the communities where they have practice locations. Why would this large, independent, kind of multi-site primary care practice be interested in these ACOs? Why? Does anyone think it's looking to define any of their practice patterns? So I'm an accountant. Remember? I'm not one of those clinical. You're a clinical person. We're going to differ here. What do you think? So let's just say the Medicare, Medicare per diem or average per capita or per year, Medicare like $13,000 excluding Part D. What percent of that $12,000 is spent within the primary care physician's office? 5%? 10%? The rest is spent somewhere else. All of a sudden, these primary care physicians now, they aren't going to control 100% of it, but they have an influence and more direct control over a much larger percent than the 10%, let's just say, that they're seeing in their own office. And now, all of a sudden, they have a financial interest in wanting to be in one of these ACOs because they have a play on the other 90%. They have a lever, and it's a pretty big lever, a 90-10 lever. Rural hospitals, frankly, have a similar lever. We only spend, what, 25, 30% of the total spend in rural communities? The rest goes out. Interesting, kind of interesting analogy here to the extent you're aligned with your primary care physicians. And all of this growth in these physician-led ACOs was before something like this happening. This was a year and a half ago. Previa Health is a large physician organization that it provides management service areas, these MSO services to physicians that want to remain in independent practice. It also has now an ACO. Now, let's just say that Previa Health is a large primary care-based practice of independent physicians, all under this overhead organization that allows the physicians to remain in independent practice. They got a $400 million expansion, national expansion grant. Right. And guess who granted it to them? Has anyone ever heard of this group right here? A little firm out of New York City called Goldman Sachs. What the heck is Wall Street doing investing in this large organization to try to keep physicians in independent practice but has an ACO? Let me give you A or B. Do you think it's because Goldman Sachs heard about the fact that primary care physicians are underpaid relative to their specialists and wanted to prop up this compensation of primary care physicians, A? Or do you think Wall Street found out about the lever? Yeah. And oh, by the way, has it happened again? Oh, yeah. Here's another one. This was this summer, or this fall. Alidade, which helps doctors run small practices, independent practices, they've now gotten $35 million of venture capital, all to try to keep independent physicians in independent practices operating in alternative payment models. Big-time dollars in capital and expertise are going after your community's independent primary care physicians. And we'll talk about why that's pretty serious. And again, all of that growth in the ACOs, so that was the physician side, and I promise you that's going to keep coming because all that Wall Street is saying, we want a piece of that lever. There is a good part of this story. Remember I told you this is going to be uplifting? So just stay tuned, all right? I got 3 slides on the uplifting part. And so, how are we doing on time? You ready to give me the hook yet? Okay, good. All of this growth in the ACOs was before Sylvia Burwell came out with her statements last January saying, hey, we want to get 30% of payment in alternative payment models by 2016 and 50% in 2018. And then what's happened is since about October of 2014, it's pretty much you can count on every 3 months out of Washington, D.C. are new regs to improve the ACOs and the alternative payment models. And oh, by the way, every 3 to 6 months coming out of D.C. are rules and regs to attack the fee-for-service model. Think about it. Count on it. So the first one, the AIM, the ACO investment model. Hey, rural hospitals aren't getting into these ACOs. Okay, we'll take care of it. And because they don't have the dollars for the infrastructure and all that. So we'll take care of that. We'll give you, you rural hospitals that want to get into these ACOs, to the extent you can accumulate the 5,000 lives, we're going to give you $250,000 up front. We're going to pay you $36 per beneficiary per year up front. And then we're going to fund you $8 per beneficiary per month for the next 3 years. There's your working capital to fund your ACO. We had 41 participants in January 1st, 2016. I know Lynn Barr, the National Rural ACO, has gotten into this big time. My understanding, she had about 150 rural communities in, 25 rural ACOs, all kind of pulling together different rural communities to meet the 5,000 threshold. Fantastic, great business model. The Next Gen ACO, this was in March of about a year ago. This came out. The interesting thing about the Next Gen, again, there's 21 of these as of January 1st. These are for the larger organizations, but I want to point to this one to say, this is how far the government is willing to go as it relates to these ACOs. We are going all the way. Payment options include normal fee-for-service payment, fee-for-service plus monthly infrastructure, population-based payment, and there's that C word. For those organizations more advanced that want to take capitation from the government, here's your check. My understanding is a lot of the Pioneer ACOs opted out of the Pioneer have gotten into this Next Gen. June 4th, we created a new time, NOR time, that the government heard that, hey, 3 years isn't enough to create this transformation so that we'd be willing to take risk. Okay. We'll give you another 3 years. We'll give you 6 years to figure out how to transform your delivery system, your payment system, and your population health system. And then they created a third track, 75%, a third track. It used to be 50-50, 60-40, and then they created this new model, 75-25, based on your level of risk you want to take. Again, improvements. Is it still happening? Oh, yep, January of this year, a couple months ago. They just came out with proposed rules essentially around adjusting the benchmark, your target. They wanted to make sure that they incorporated a regional rate because they heard say, hey, we're already at the low-cost provider in our region. And if we take any costs out and you reset our benchmark, we can't squeeze kind of blood from a stone. So CMS said, okay, you're right. That makes sense. We'll give you a regional, your target will be set factoring in the region's cost per spend. And so again, every 6 months, every 3 to 6 months, we're seeing improvements in the alternative payment model regulations, and we're taking from the fee-for-service payment models. And just count on that. Are we seeing results? It's interesting. It's a little bit, as somebody that I'm very bullish on these, if you can't tell. It drives me crazy that we haven't reported 2015 information, or we're still talking about 2014 results. There's no run of real-time accounting for these ACOs right now. So 14, we did see improvements. 92 shared savings programs held spending $806 million below their targets, and incentive payments of $341 million. So we are seeing some results, and oh, by the way, I know one of the BKD guys mentioned it this morning. This was a news release that just came out a couple weeks ago. Yeah, a couple weeks ago, that the government has now said we actually met our target of 30% of Medicare payment in alternative payment models. It was supposed to be by the end of 2016. They've already met it. So the results are starting to come in, and we're seeing this stuff happen. And so you keep coming back to this model. Why is this happening? Why, when the market said they were never going to happen, and now these ACOs are all over the place and gaining speed and improving, and we're seeing all this movement. And it became very clear to me a couple of years ago. I was working with 4 critical access hospitals in northern New Hampshire, and they were looking at creating a shared savings company to kind of take out. They were targeting a 10%, taking out 10% of their operating costs through this shared service company. So 4 of them all bought into this, and frankly, when you run the numbers, the potential savings from a shared service corporation was about 1.5% of their operating budgets. It wasn't going to get them what they needed to get to, at least what they targeted. So they said, all right, so the project became more of a population health. How are we going to position ourselves for this new world of population health? And so the first thing we did is we ran a 10-year financial projection staying in fee-for-service, making some assumptions around kind of impact of the ACA and some of the things that we've talked about. In New Hampshire, Blue Cross is actually paying their subscribers $250 to leave rural communities and get their outpatient surgeries in ambulatory surgery centers in Concord, in the capital. Writing a check to their beneficiaries to leave rural communities. And so the hospitals, and this continues to be in place today in New Hampshire, but we had to factor that into some of the reductions in utilization, especially around outpatient surgery, which is bread and butter for many of these critical access hospitals in New Hampshire. We assumed some reductions in the ability to negotiate with third-party payers. We maintained cost-based revenue. But essentially, when we ran this 10-year model, it became the holy cow scenario. And I'll show you a little bit about what that looked like. So just if you look at Iowa, if you're looking at your Iowa, your discharge rates per thousand now around 100. Milliman has projected by the time that we get out to, like, say, 2021, 2022, in highly managed markets, discharge rates could be anywhere from 42 to 70. You saw that rate of decline that you've experienced just in 6 years in Iowa. Now, I don't think it could continue at that rate. But when you start dropping in a 2 or 3% volume reduction to inpatient services, and not necessarily to critical access hospitals, because you'll get it back on the cost report, but the PPS hospitals, it's a different world. You put that into a financial performance, and this was the result that you're going to see. And this was the combined performance of these 4 critical access hospitals, and it became the holy cow scenario. Essentially, anyone that's planning out, looking at fee-for-service revenue, and maintaining your costs and services when volume's coming out and price relative to cost is going down, this is what your financial performance is going to be out in anything longer than a 1 or 2 year budget period. And so, essentially the whole thing around these accountable care, this is not the government saying you have to do this. These are the folks looking out beyond this 1 or 2 year cycle, their budget cycle, and saying, this fee-for-service world, this dog don't hunt anymore. And we've got to start moving our payment systems now why it's risk-free. And that's why, I believe very fundamentally, that's why we're seeing the big jumps that we're seeing. And so I want to say, how is this all playing out right now today? I think both Mike referenced this, and I think George or Dr. Pink mentioned this earlier, that we've got hospitals closing. Those that have not figured out that price and volume are being attacked and are maintaining this fee-for-service pillar are not able to take out costs as fast as price and volume are coming down. And what's really interesting, and for you all in the back row, this says there's been 71 rural hospitals closed since 2010. All right, that's over several year period. That's not a bad number. It's 6 years. I will tell you, I updated this presentation in December, and the number went from 56 to 66 between August and December. The number now is 71. The 5 that have closed since December, literally 5 rural hospitals have closed since December. And I would love to see, and Mike, maybe you have this information available, but the rate of closures now is I think is accelerating because you're seeing some of the impacts here that we've just talked about. And so here's, I'm going to go back to Louisiana, because all of this was background information that we presented to the critical access hospitals as, here's what's going on in the market, here's some of the impacts of the Affordable Care Act. All of this is playing out. And then the next exercise was, okay, let's identify all the challenges affecting CEOs that are keeping CEOs of rural hospitals up at night. And the thinking was, if we could identify the kind of the subset of those challenges that have just come on the kind of the scene, why don't we point to them and say, that's what's kind of that's what's the underlying cause. And then if we could identify that, let's get strategies in place. So we went through this brainstorming exercise, identifying all the challenges keeping you all up at night. I think the challenge keeping you all up right now is the speaker. So come on. Anyway, this was some of the things that we talked about. Difficulty with recruitment and aging of current medical staff. That's a challenge keeping most of you up in this room. How long's that been going on? Increasing competition from other hospitals and physicians for limited revenue. Been going on forever. Small hospital governance members without sophisticated understanding of small hospital strategies, finances, and operations. I'm sure not your board members, but every other board member that I've had a chance to see. Consumer perception, if bigger is better, limitation on the next. All of this stuff are challenges keeping you all awake at night, been going on forever. And then you get down to the bottom three. And we had a lot of discussion around the fact that the payment systems are going to change. And they're going to change. They're moving to this fee-for-service to value. What the heck do I do with that? The quality is a payment and market differentiator. People that are doing quality, it used to be quality was an office. Quality now is a market differentiator. People are competing with their quality scores. Those that are doing it well are plastering billboards all around their communities. You go to Louisiana, New Orleans Airport, you step off the plane, the first thing you see, Ochsner Healthcare, best in primary care and orthopedic surgery or something like that. People that are competing with their quality scores. And the last one is that the payments costs are coming out. You can't just go back your truck up to Des Moines and get money from the state capital for rural hospitals. It used to be, back 10 years ago, we could woe is rural, woe is us, we can get some money. That is not happening anymore. So what's interesting is if you pull those three together, and we pull them right here. I was asked a month after the Louisiana project, I was asked to speak at an ACHE conference on the rollout of Don Berwick's triple aim in rural healthcare. And you know, I was asked to put together some comments on it. It was at that time what I realized was that the three market challenges that have just come on the scene as presented by Louisiana and then confirmed with the Tennessee a couple years later was essentially a market competition on Don Berwick's 3 points of his triple aim. A movement to population health, efficiency, and quality. And it was a market competition around the three of them. And as I started thinking about that, it took me to this article right here. Does anyone in the room remember this incredible article by Michael Porter, the economist from Harvard? Anyone remember this article from 2004 called Redefining Competition in Healthcare? So in this article, Michael Porter, famous Harvard economist, right? Porter's 5 Forces, we all studied him in MBA school. He talked about the fact that the competition is not the root of the problem in healthcare. What the industry has chosen to compete on for the last 30 years is the root of the problem, in that we've competed on the zero-sum game of shifting the buck between providers, insurers, and consumers with no fundamental impact on the biggest economic driver. And when in this article, he said, when we start a market competition on the biggest economic driver, we are going to see costs come out and innovation come in, unlike we've ever seen in the 30 years of our, the entire history of our healthcare system. And he said, when we get to be that highly competitive state, competing on the biggest economic driver, think of our industry like the telecommunications industry. Innovation coming in, costs coming out. Think about Gordon Moore and Moore's Law. Right? The speed of a processor is going to double at half the cost every 18 months. Michael Porter went and said our healthcare industry is going to be that competitive. Well, guess what he defined as the biggest economic driver in healthcare? Patient value. We as an industry have started a true competition on patient value. We are going to see innovation come in. And if you think about it in the last year, all the articles that you're seeing, all of the innovation that we're seeing, the home care remedy, all these home care technology that's coming around, all of this monitoring stuff for patients, all of this, I do believe is this whole thing about this new competition on patient value. And I would think of it and say, if he's right, I would say we got a big meat grinder and we've got a bloated sick care system, supply-driven sick care system that's going to come into a meat grinder, and what's going to come out is going to look very different on the back end. And what our goal here is to figure out how to come out shining on the back end. And I think there's an incredible opportunity for us. So here, we heard this earlier today. I look at patient value. Let's define it. Quality going up, maintaining cost applied to a population, or quality maintaining constant with costs going down applied to a population. or quality going up and cost going down. All of these things are going to increase patient value, which we're going to be competing on. I look at accountable care, and you're going to hear me very bullish, as a payment concept, follow with me on this one, where providers monetize the value derived from increasing quality, reducing cost. Let me say that again, because it's really, I look at accountable care as a payment system where providers monetize the value of increasing quality and reducing cost. And it takes lots of different forms. And here are all the different forms it takes. Anywhere where providers come together to monetize the value of increasing quality, reducing cost applied to a population. Bundled payments, value-based payment. Providers self-insured health plans. Think about that one. Medicare ACOs. All of these things make up this payment system called accountable care, little a, little c. And it's different this time. It's different than managed care. If you stop and think about managed care, who monetized the value of increasing quality, reducing cost in that managed care era? Insurance companies or providers? Insurance companies did. Who had the greatest ability to affect quality and cost? Insurance companies or provider organizations? Yeah, we had the incentives completely backwards, and we thought it was going to work. And in addition, at the time, remember we did all that managed care stuff for what? 10%, 20% of our payer mix? Well, not this time around. The government's all in this new world, going all the way to capitation in this next-gen ACO. New information systems to manage quality and cost, agreed upon evidence-based protocols, and going back is not an option. This is one, Ian, I kind of spoke at a conference with Ian Morrison. Anyone ever heard of the Scottishman, Ian Morrison? Great speaker. He's one of these futurists. Futurists get paid, what, like $20,000 to come speak? Accountants don't get paid $20,000 to come speak, let me tell you. Anyway, he talked about the fact that as a healthcare industry, we have gotten so expensive at marginal quality that we have priced the rest of industry out of business on a global economy. When healthcare costs make up, I saw this in one of his slides, he talked about the fact that healthcare costs are the biggest piece of the cost of a car. Instead of steel or something like that, it's healthcare insurance. We've priced the rest of the economy out of business on a global scale. And so we've got to get it right this time. And so that's why I think this new payment system is an approach that we're going to get there. Because we are going to monetize that value that we create. How does this apply to rural? So here are my 3 slides on the value of rural. You're going to like this, okay? Promise. Wake up. When I was reading the regs, the ACO regs back in March of 2011, one line in the regs, whatever, hundreds of pages of regs, jumped out at me, and it was just one of these like, oh my gosh, this is the new world. And it said a primary care physician can belong to one accountable care organization. Hospitals and specialists can belong to multiple accountable care organizations. Now remember, I'm an accountant. Why did that one line jump out at me as like something I had never seen before that was the most important thing I've ever read? Think revenue centers and cost centers. How many times can you credit revenue to one? The credit is the good side on the income statement. How many times can you credit income to one organization's income statement? Only once. What that just told you, that one line that said a primary care physician can belong to one accountable care organization, hospitals and specialists can belong to multiple ACOs, just told you about revenue centers and cost centers in the new world. The primary care physicians are your new revenue centers. And rural hospitals that are aligned with their primary care physicians have incredible value in this new world to the extent that they have strong alignment, they're running efficiently, and they have high quality scores. So I got a couple home run slides. The first one, that Michael Porter one, that was good, right? Give me that one. Uh-oh. Maybe not. All right, I got one. One person thought that was good. This is my second one because this is just going to compare and contrast fee-for-service payment with population-based payment. So in a fee-for-service world, all our costs start out relatively high at no volume. So here's volume, here's costs, or dollars. This blue line is our expenses, and the orange line is our revenue. So in a fee-for-service world, our costs all start out really high. Think about this as drive around your patient parking lot at 8 o'clock on a Monday morning, and then go around the back and look at your employee parking lot. That's high fixed cost, low volume. But for every incremental unit of service within our hospitals, our costs go up a little bit. What did your costs go up last night when you admitted your 6th patient from the 5th patient? Not a whole lot, right? So tiny, tiny bit. So the slope of our cost line is very, very shallow. But how much revenue did we generate on that one extra patient? Let's just say our per diems are $2,000 a day. So our revenue line is pretty steep. So as a fee-for-service, in the fee-for-service mindset, how did we maximize this world? 2 ways. We pushed out volume, which at a very steep sloped revenue line, it's going to catch up to the shallow sloped cost line pretty quickly. The other thing we did is we increased the slope of our payment line. What is a great strategy for increasing the slope of our payment line? I'll give you a hint. Neurosurgery. Right, for 1 unit of service, we generate $50,000 in revenue. That increases, on average, the slope of your payment line. Now, who maximized that world? Rural hospitals or urban hospitals? Yeah, urban hospitals. Now, let's turn this baby upside down, and we're going to go to this new world of population-based payment. How do we grow revenue in a population-based payment world? Oh, you've heard this presentation before, haven't you? You attract lives. You gather lives. Who are lives attached to? Your primary care doctors. So let's just play around with numbers here. Average per capita healthcare costs in the United States now, around $10,000. You take all the costs of healthcare, divide it by the population, around $10,000. A busy primary care physician's practice has, on average, 2,000 patients in their panel. What is the value of one primary care practice in this new population-based payment world? I've given you all the numbers you need to know to be successful in this. It's 2,000 times 10,000. What's that number look like? Does anyone think it's $200,000? Does anyone think it's $2 million? You guys are good. You're just not raising your hand. It's $20 million. It's $20 million. Your rural hospital that's aligned with, what, 6 or 7 primary care physicians with full practices, now with full practices, obviously, is worth $150 million in that new world. For direct costs of what? 40? And oh, by the way, now, in this new world, what just became the new cost center? Specialists, technology, and bricks and mortar just became the new cost centers. A new sheriff in town. Who has value or potential value, future economic value in this new world? Urban or rural? Urbans are figuring out right now how to get lives in their system. They're trying to figure it out. I was in Kansas 2 or 3 weeks, I don't even know, 2 or 3 weeks ago. And working with a rural demonstration hospital, and their large affiliate, their large system partner came to this meeting, and the CEO, and he said, this presentation, right on, we are trying to figure out how to get lives in every nook and cranny of the region, going out as far as 50, 60 miles. We're going after those lives. You have them, to the extent you play your cards right. We have incredible value in this new world. The big boys that now, when technology specialists and bricks and mortar become part of costs, are trying to figure out how to diversify costs with new revenue streams. And so, rural hospitals, this is on slide 40. We're at slide 40 now. Just a joke up here, sorry. We have value. One, we're generally lower per beneficiary costs, as Mike talked about. We're just revenue centers of this new world. Disproportionately, we're revenue relative to cost versus the inverse of which you're going to see in many of the larger systems that have spent the last 30 years designing a specialty network, thinking primary care physicians are your lost leaders. And then cost-based reimbursement. Here's one for you. We're all critical access hospitals in this room. I think cost-based reimbursement is the payment system of the future. Pay attention here. And why is cost, but let's not call it cost-based reimbursement. Let's call it budget-based reimbursement. So if we start thinking about cost centers today, how do you cash flow? How do you provide incentives for your cost centers in your hospital today? Think housekeeping. Don't you give them a budget and you hold them accountable for that budget? Well, in the future, if hospitals, if bricks and mortar become cost centers, don't we want to decide how to give a hospital a budget and hold them to that budget, but flex it based on changes in volume, maybe flex it to the tune of their variable cost, which is 10 cents on the dollar of total cost? Isn't that kind of budget, flex budget-based payment in this new world when hospitals are not revenue centers anymore, they're cost centers? I suggest we're onto something here with this critical access hospital, this cost-based payment. But let's stop calling it cost-based. Let's call it budget-based. And then we just got to sell it to Congress. You guys got that job. So I do think that. So what we got to do is we got to figure out, we actually may finish this presentation on time. I am so excited. We got to figure out how to get from here to here. We have no business being over here right now. We had a lot of business for being over here until this started to go away. This is fee-for-service. And the fee-for-service, it was a completely stable platform. And it's a stable platform because we have 100%, our delivery system and payment system are 100% aligned. From an accountant's perspective, the more we do, the more we make. Perfectly aligned. Over here, we have an aligned payment system. This is called population-based payment for you guys in the back. We have a perfectly aligned payment and delivery system. From an accountant's perspective, the less we do, or the more we do around health, the less we do around sick care, the more we make. Perfectly aligned, perfectly aligned. Everything in here, and I think the guys from BKD showed that slide of this coming down over time, this coming down and this going up is a disaster because we've lost that 100% separation between payment and delivery. Right? We kind of, and oh, by the way, we have a new time frame for this. And I would say it's somewhere between the implementation of the MACRA. So it may be 2022, 2023, 2024 when we're looking at it. And oh, by the way, that's only 6 years away, which is about the time from the Affordable Care Act was passed 6 years ago yesterday to today. Here's my third home run slide. If you close your eyes, but not too long, and think about it, this slide will tell you everything we need to know about what the future world is likely to look like. The premise here being that form follows function, follows finance. That's a pretty straightforward concept. We have a financing system right now based on a fee-for-service. If we think about the functional imperatives of a fee-for-service payment system, it's about one managing one's own price, one's own cost, and one's own utilization. And if one can manage one's own price, utilization, and cost in a fee-for-service payment system, one can be very successful. So what was the form that we got out of that? We got a bunch of ones competing with other ones on their own price, utilization, and cost. But that world is going away. We all recognize we're moving to this new world of population-based payment. Think about the functional imperatives now of a population-based payment system. It's managing a population, your community, your 20,000 or your 10,000 in your community. We can't do that anymore alone. Public health's going to be in there, home health, ambulance, your physicians, your tertiary providers, nursing homes. All of these organizations are going to come together to manage the health of a population while accessing sick care. It has to have scale because the providers are increasingly under these accountable care payment models. We're going to have to take risk. And so, the CEO at the large health system in Maine, I was at a meeting with her a year ago. She said, we're looking for 250,000 covered lives in our health plan, our ACO, before we feel we can diversify insurance risk. So if those are the functional imperatives of a population-based payment system, the form that's going to have to fall out of that are aligned organizations competing with other aligned organizations for covered lives based on quality and value. This is the new world. And I look at states like Pennsylvania, right? You got Geisinger, which is an integrated insurance, physician, hospitals, coming down out of the north central, coming in Pennsylvania, coming in this way. You got UPMC, that used to be University of Pittsburgh Medical Center, that created a large insurance product that then acquired hospitals in Altoona, which is central Pennsylvania, Erie, Pennsylvania, northeast, competing with Highmark, which used to be Blue Cross Blue Shield of Pennsylvania, western Pennsylvania, that has acquired hospitals all over western Pennsylvania to compete primarily with UPMC. It's the narrowing of not so narrow networks. In Kansas 2 weeks ago, 3 weeks ago when I was there, the CEO of the large health system there, he said that he thought in Kansas there would probably be 4 systems in Kansas, by the time this all plays out. 4 large, not so narrow networks. And if this premise holds true, I don't see another way this is going to roll out. Do you? And so those were 3 home run slides. Every one of them good. Because if I tell you this is my grand slam slide, will you let me explain it to you before you give up on it? Because it's really detailed. Here, I'll give you another tidbit. I had the chief medical officer of the Georgia Hospital Association. He referenced this slide by saying, Eric talks about the shaky bridge. He said, this right here is the concrete path through this transition. That's what he said. I quote him on it. So I'm trying to build you up to at least pay attention while I explain it to you. Otherwise, after the first 30 seconds, I'm going to lose all of you if you have the ADD that I do. So right here, we ended up, this came right out of the project in New Hampshire I was telling you about with these 4 critical access hospitals. And what we realized is that we've got to come up with tactics that are going to move us through this strategy of conversion from fee-for-service to population-based payment. This was the group that ran the numbers, and their financial performance and cash reserves were depleted by the 10 years were out. They wanted to do something different. And so we came up with this as a tool to help them think about it. So let me explain it. You guys, let me explain it and give me 2 minutes. Going across the top is the transitioning payment system. This is measured in time from fee-for-service. Think of this as accountable care light, medium, heavy, full population-based payment, the narrowing of not-so-narrow networks. Down here, the y-axis, there are 3 key areas that we have to, 2 key areas that we have to transform and 1 we have to create. The first area we have to transform is our delivery system. Think of this as the sick care model that we are today. Access to sick care. We have to transition this. The second thing is we have to create a health system. We do not have a health care system. Every time I say healthcare now, I kind of think of myself and like, do we really have healthcare? It's on every single one of our mission statements within our hospitals. But if we actually did this really well, we'd close. And then we have to transform payment. And so what this is saying is, okay, to transform the delivery system, there are 3 key initiatives that we've got to do. The orange line is the strike point. There's a strike point coming up, strike point, strike point, strike point, strike point. You see the orange lines there? Yeah, you got it. First initiative right here. This initiative has hit the strike point. We've got to do this. Implement. And this is going to roll off my tongue real easy. Operating efficiency, quality, and patient engagement implementation. We have to think about taking 5% out of our cost structure here by being more efficient. And I've got some slides on this. If we don't do this well, we are going to lose 5% of rural hospitals. And just based on the earlier slides, we're already losing them. They haven't been able to keep up with this as we move to this payment system has moved. The second thing is we have to align with our primary care physicians by the payment system gets to phase 2. Clearly, we have to align with our primary. These are our revenue centers once we get out beyond here. If we don't align with our primary care physicians by the time we get to here, somebody else will, and there goes our value. So today, we've got to start planning. Today, we got to start planning to have that alignment. Maybe you have an FQHC in your town. Maybe you have independent practices. Is there an opportunity around a PHO? What's that model for alignment that we've got to have? We're going to lose 10% of rural hospitals that can't do this. The market's going to do this involuntary. The market's going to do this involuntarily when the big systems are, Previa Health or whatever the other one was. I don't even, they start coming in and taking our primary care physicians. The third initiative down. Think about this as right-sizing our sick care model, our fixed costs to a new and lower demand curve for sick care services. So we call it service network rationalization strategy, right? Service area. Think of this as coming together, alignment over time. This is strategy, implementation plan, strike, to take out big chunks of future fixed costs. And by the way, think about taking 20% out of the cost structure here. But by the time we get out here, what are your big chunks of fixed costs? Specialists, technology, and bricks and mortar. How many of those do we have in rural? Generally, our specialists and our technology and our infrastructure has been built to serve the community we have. We haven't overbuilt to serve communities all around, 50, 60, 70 miles around us. Big chunks of fixed costs in the future are something that most of us don't have. Now, I will tell you, my 4 critical access hospitals in northern New Hampshire, 3 of the 4 in a 2-county area have 24/7 general and orthopedic surgery. Now, in this heavy fee-for-service world, you don't even want to start talking about that because those are your revenue centers. Those are your profit centers. But when the payment system gets out to here and we're in accountable care heavy, do we still need 3 hospitals in a 2-county area doing 24/7 general and orthopedic surgery? Or are those surgeons now big chunks of fixed costs that can be right-sized to meet a new and smaller demand curve? So this whole thing is about right-sizing our sick care model for the new demand curve. Think about this as creating a health system, creating healthcare. Right thing, patient-centered today, what we can do today, patient-centered or like models, patient-centered medical homes, develop care management capabilities, the data analytics, a lot of stuff Mike was talking about. The better we can get at data analytics today, learning is going to be, with data we ask. I had a good friend of mine, he's a physician, actually he's a professor here at Rupri, University of Iowa, School of Public Health, Clint McKenney, and he talks about the fact that hospitals should get into ACOs for the data alone, have access to that data, be able to look at data and kind of look and see what that's doing. Evidence-based protocols. Here, this next phase, we got to strike all of these. Payer network contracting, hotspotting, value attribution. This point right here is a really important piece. How do we figure out how to credit our income statement for doing what's right in population health when right now our income statements are measuring value in a gap basis fee-for-service world? Everything we do right now around health shows up very poorly on our income statements. And so what's this value attribution? And what I tell hospitals is you should be sitting with your ACO counterparts, whether it be a big system, big hospital, but figuring out that value attribution model. How does something we earn in our community either come back to us or somehow get credited back to us or cashed back to us? We've got to figure that out. I would suggest that one of the biggest pieces that's holding back the movement to population-based payment is gap basis financial statements that measure and accrue income based on a fee-for-service, gross charges less contractual allowances. The extent we start thinking about, I was at an HFMA meeting in Maine back a couple weeks ago, and I brought this up. When are we as an accounting society going to start to figure out how we're going to credit income to reflect creating health in our communities? If we could do that tomorrow, we would jump light years ahead of where we are today. Any of you guys can figure that out kind of in your garage or something like that, let me know. I'll come, we'll sit down and we'll make a fortune. So the last piece, so sick care, create a healthcare system, and then the last one is transition payment. And the transition payment, right now today, if we have a self-funded health insurance plan, let's take that health plan and actually use it to create incentives for health, and then take our employees in that plan and put them into our health system. We're already fully at risk for this. Take our employees and their dependents and create a kind of a lab for understanding and getting better at health. We're already at risk. Transitional payment models, strike in the future. This is ACO, shared savings. We're not at risk. And then up here, full risk. And we don't even know what that means. We're in no position because we haven't developed the health system yet. But it's but we've got to get there. So essentially the beauty of this model, it takes this concept of population health. How many conferences have you gone to and you hear people talk about this noun of population health? And you get done listening to someone talk, and you're like, what the hell are they talking about? At least that's for me. I look at population health over the next 7, 8, 9 years as a verb. And it's a verb that plays out moving, kind of creating a payment system, changing the payment systems down here to fund sick care, maintaining access to sick care, but creating health care. Fee-for-service is not that payment system. The second thing it does is that it takes up, it aligns. We can be doing all of these things today. We should have on our operating agendas, we should have 7 items listed. And every single one of these should be here. Because this maximizes fee-for-service. Everything in these 7 nodes maximizes fee-for-service, but creates a pivot position for the new world of population health. Everything we do here does not hurt fee-for-service, but further creates that pivot position. Once we get out here, we're all in population health. That was more than 2 minutes to explain this. Now let me just kind of go through it. So what is patient safety and quality? Well, first of all, this first box, we got to be operating efficient. Efficient means, first and foremost, having the appropriate patient volumes. We cannot cut ourselves to success in a fee-for-service heavy world. We've got to maintain and figure out ways to grow volume. And one of the things what has really come really interesting to me over the last 2 years is kind of using another baseball analogy of your department managers in your hospitals. If you look at your department managers and using a baseball analogy, categorize them either pitchers or catchers. Could you look at the performance of your pitchers, your department managers who are pitchers, versus the departmental performance of your catchers? And a catcher is somebody that sits behind the door. When the volumes don't come in, they point their fingers at the doctors and say, hey, it's the doctor's fault. But every single one of you has a pitcher that is out there in the communities, involved with Rotary, out meeting with the doctors, out marketing their services. And every single one of you, their departmental performance exceeds the catchers by 10 to 1. What is our opportunity in our rural hospitals to take all our department managers and move them towards this pitcher mentality? I challenge you all on that one, because I promise you there's an opportunity around volume in there. Revenue cycles, if your days in AR are greater than 45, outside of extraneous Medicaid, state Medicaid issues or something like that, we're missing something here. I was at a critical access hospital in New Mexico a month ago, and they were part of the Presbyterian Health System that just got an HFMA, Healthcare Financial Management Award a year ago for top revenue cycle system in the United States. This critical access hospital in even in light of all of this extra self-pay payment and showing up in their bad debt and all this stuff, their days in AR were 34, both net and gross. They were doing everything up front. Patients were called, discussed co-insurance amounts. They knew all of these things. They had moved essentially 80%, 90% of the revenue function into registration, pre-registration, and it was paying off in spades for them. Unbelievable. Expenses managed aggressively. Just because we're critical access hospitals doesn't mean we can't manage expenses. Physician practices managed, and physician practices, we've got to get those experts in physician practice management because increasingly we're going to become closer together with our primary care physicians if you believe in anything that I talked about before. Know your quality scores. Being able to compete with every hospital in your region around your publicly reported quality scores. This is something we're going to be competing with. Where do we stand relative to all of our competition? You can see this hospital was okay, not the best. I would say a strategic goal for these guys is in 18 months, these scores are better than everybody around them. Primary care alignment. If you guys walk out of this room with nothing other than understand that value of that primary care in this new payment world and lock them down, that's all I care about. Really, that's all I care about. So that first point is understand how important they are in this new payment world. And with that understanding, I look at and I use Stephen Covey and his models of dependence as a really important kind of way to think about it. So he talks, Stephen Covey in his, this is, remember the 7 Habits book from 20, 30 years ago? He talked about dependent, your 5-year-old, independent, your 18-year-old, and interdependent, your 26-year-old. Supposedly, I don't know what that is, but I know it's got to be better than the independent model of the 18-year-old. And look at all of your primary care physicians in your community, whether you employ them or they're independent, and think of them as independent first, and your goal is to seek out this higher level of relationship, this interdependent relationship. And as we kind of pulled together this model, we call it this interdependent model of alignment. And it's really going to be based on a 3-legged stool, this one piece, of functional alignment, contractual alignment, and governance alignment. We ought to sit down with our primary care physicians, or you ought to inventory each one of them and say, where is our functional alignment, contractual alignment, and governance alignment with each one of our primary care physicians in your community? And seek out opportunities. Now, obviously, your contract, employment agreements are your highest level, but just because they're employed does not mean they're aligned. So, a new PHO. I mean, I'm seeing the PHOs come back up as a model of aligning primary care physicians. A couple different rural communities I've been to now are reestablishing PHOs that were put on the blocks years and years and years ago when the managed care era failed. Opening them back up as an alignment tool that addresses all three of these, the 3-legged stool of function, governance, and contractual alignment. This is super important. This next one is we're moving third down, the delivery system, and this is just, is there that interdependent model of alignment for larger systems and the organizations that you're going to have to align with to create the infrastructure around population health? Using that same dependent, independent, interdependent, seeking that higher level relationship, maintaining elements of independence in your rural communities. Payment system. What are we going to do around our payment system? Today, again, as we talked about, we're already at 100% risk for our own employees. Start there. And we say, oh, no, we have Blue Cross. Well, let me ask you this. Is Blue Cross just you're self-insured but 1 year removed? In most communities it is, because they'll just build your current year experience into your next year's rates. Maybe it's different in Iowa, but everywhere else it's not. So start there. Build a health plan with incentives around consumerism. In Maine Health right now, annual blood tests. If there's nicotine in your blood, $43 per pay period, higher premiums. Good buddy of mine, he's CEO of a critical access hospital in Mississippi. He sits down once a year with a health coach. They define targets for health improvement, and he's got to have movement towards those targets. People are getting kind of creative around this. You start looking at these ACOs, and you guys, many of you are in the room, are already in them. I've seen really interesting levels of adoption. I'm hearing some It's like those organizations are fully engaged in ACO, creating the health systems, saying we're going to get the returns. I'm seeing the ones saying we don't want to do anything because anything we do today is going to get built into lower targets for when we have to take risk. And I'm just seeing, I was at a critical access hospital in Nebraska. They got into a system-led ACO, and this was May, and they got into it back in January, and said, you know, what have you guys done differently? Nothing. We're just in it. You know, so you know, it's really interesting, but you know, kind of get into it. Get that data. Get at data analytics. Start looking at what that means. Develop that data analytics infrastructure. And then the last one here is to create this health system, you know, and think about it as crawl, walk, run, sprint. In the end, there's a bunch of stuff in here that we need to get through, but some of this stuff, patient-centered medical homes. How many of you have patient-centered medical homes, or kind of you're in that direction within your primary care practices? Right on. Discharge planning, start this transitions of care, all of this stuff, claims analysis, all of this stuff is in this first phase of creating this health system, this crawling phase of a health system, to not get too far out in front. So I go back to this and say, the way this is structured, it takes this concept of population health and breaks it down into bite-sized pieces that all of us can be kind of moving on. Every single one of our discussions ought to be, what are we doing here? What are we doing here? What are we doing here? How are we doing this? What are we doing here? Because all of this maximizes fee-for-service, but creates a pivot for this new world. Again, then out here, as we talked about, a pivot to this new world. We do not want to get this and this ahead of the payment system. If we do, we're in trouble. We will close, and Blue Cross and the government will thank us. And that's not what we ought to be thinking about. So kind of in conclusion here, I do believe that we are in this world of a competition on patient value, which changes everything. Costs are going to come out, innovation is going to come in. The payment system of this new world that is going to be able to both fund a sick care system and fund health care at the same time is not going to be fee-for-service. It can't be fee-for-service. It can't be, because if you fund population health, if you fund a health system, you will close a sick care system. So we've got to get this payment system to more of this bundled approach. This triple aim is where we're going. The shaky bridge, we've got to be proactive, and we've got to move across it. Because if the longer we stay out in the middle of those three transitional areas, the tougher it's going to be. Once we step out, we're going to have to move across. As I would suggest that the world that we once knew, this stable fee-for-service pillar, does not exist anymore. What are the most important things we can do? One, get leadership awareness of our new market environments. This presentation, if it was all interesting to any of you, it's going to be up on the website for the Iowa Hospital Association. Get your boards to understand that there's a new sheriff in town here. Start a strategic plan. Take a look at your strategic plan. And make sure your strategic plan hits on all 7 of those nodes. And if it doesn't, is there opportunities to bolster your strategic plan given kind of this new market reality? Focus on this operational improvement. And operations improvement and efficiency is a measure, again, of cost over volume. Most rural hospitals have the biggest opportunity to affect efficiency through volume gain than taking out cost. Our costs are in good place in most places. Quality and get our quality system so that we can compete with everyone. Align partner with our medical staffs, contractually, functionally, and through governance where appropriate. And then start to seek out these larger system relationships, hopefully maintaining that independent but interdependent model. So I like to think that we're going to be judged. 20 years from now, we're going to be judged. And we're going to be judged by our kids on the decisions that we make right now and over the next 5 years to create a health system from a sick care system. Frankly, I want to be, and our kids are going to look back and say, boy, those guys either had it right there and they failed, or they did all the right things. I would like to be part of our kids looking back and saying what we did today and right now in this room and everywhere in this country, that we've done the right thing and we're able to create a true health system from a sick care system. So I appreciate you guys listening for an hour and a half. Sorry to keep you all awake. Thanks.